I'm going to introduce the first speaker, Professor Heide Sickelkopf from Germany. She's a professor at the University of Göttingen. And Heide has done a lot of work in hypopara, and especially with a focus on quality of life assessment in these patients, and really published some seminal papers on how severely quality of life is affected by this disease. So with that, please, Heide.
Hello, everybody. Good morning. My task is to talk about current standards of therapy and practical problems and limitations in everyday management. So these are my disclosures. So treatment options, we heard a lot about it. So we have conventional treatment. We have parathyroid hormone 1 to 84. In some countries, we have teriparatide. So my task is to talk about conventional treatment. So activated vitamin D analogs, Peter already talked about it a little bit, and calcium supplements in divided doses. This is according to guidelines. You can also, you could use high doses of cholecalciferol. You should add vitamin D supplementation and magnesium if needed. Peter already explained a bit, so I have not to explain too much about vitamin D metabolism, but it's really important to understand the different vitamin D analogs. So cholecalciferol, so what is synthesized from the skin is also in nutrition, but mainly it's from the skin. This is activated from the liver to 25 vitamin D, and this is what we measure very often in the blood. So together with PTH, this is activated to 125 vitamin D. So if PTH is missing, we don't have 125 calcitriol, so the active hormone. So this is substituted with different drugs in the different countries. We had also dihydroterol, but since last year, this is not available anymore in Germany. So you could also take high levels of cholecalciferol if there is the rest of PTH available. Then you could also use high doses of cholecalciferol, and then you could increase the 25 vitamin D in the blood, and then you would perhaps have enough 1 to 25 D3. So why is it so important to have this calcitriol? So if you just remind us from the regulation, if calcium goes down, PTH goes up. PTH is can induce calcium from bone if it's necessary, so we have enough calcium there, but mainly it's also responsible for the resorption of calcium in the kidney and activation of 125 vitamin D, and only this is responsible for the resorption of calcium from the gut. So if you don't have 125 vitamin D, you can take as much calcium as you want, but it's not resorbed from the gut. So this is the important point for 125 vitamin D. And if you don't have PTH, all the different mechanisms don't work anymore, and 125 is missing also. So just to remind us all that there's a difference between the action of PTH. Already also Peter pointed it out, but just I think repetition is not too bad. Calcium goes up with PTH, but also with 125 D3. But PTH decreases phosphate in blood, and 125 with 125 D3 phosphate goes up. So we have different medication with different potencies. We have this different in a number of countries. Not every medication is available in every country. So they have different start of effect, different duration of effects, and also the daily dose is different. So this is also different in a number of countries. So on the way to this talk, I try to find studies to comparing the different medications. So I found one study, well-done study on comparing alpha-calcitriol to calcitriol in idiopathic hypoparathyroidism. And this is a complicated slide, but what they try to do, they try to really adjust the different combinations to the patients so that it's really well adjusted to the different situations. and they had 25 in calcitriol and 20 in the alpha-calcidol arm. And what they concluded is they both control calcium well, but they lead to high serum phosphate, hypercalciuria, but physiological circulating 125 D3 levels. So what about how is quality of life with the treatment? So as you may know, there are several tools and from this so-called prompts, so to evaluate quality of life. And one of these we developed is the HAPI-Q28. So in a study, we investigated the effect of vitamin D treatment on symptoms. This is a 2-center cross-sectional study. The patients had 12 years. The therapy is like 50 patients we investigated. The age was like 57 years, predominantly female. And you can see we had some in the group, no active vitamin D means they have just calcium and high levels of vitamin D. So calcitriol, alpha-calcidol, and dihydrotachysterol. And we did not see a significant difference in the different parameters. And what is interesting, we looked how well adjusted to the guidelines our patients were. And you can see that from the main calcium phosphate and calcium phosphate product, calcitriol seemed to be very good and dihydrotachysterol were very good. But also in our group, not all that were adjusted in calcium, for example, in the urine. Then now we compared the different symptoms and complaints, what we have. And although you don't see any difference between the different groups, interestingly, we saw that there was a dose-dependent effect of calcitriol on different and pain and cramps, depression and anxiety, numbness and tingling in our group. And this was not dependent, it was independent of gender, age, underlying disease, kind of surgery, 25 vitamin D, calcium or phosphate values. We also, and I just copied this formula, but this shows you from Peter, this is the slide from Peter, that magnesium is very is important for neuromuscular function. And although you don't see a significant difference between magnesium values in the different treatments, you still see that those with intake for magnesium have more complaints, or this correlate to more complaints in different groups. Some are significant and some are just a tendency. So we can also see that the intake of magnesium supplements and the use of use of calcium influences the scales and symptoms and complaints in patients with hypoparathyroidism. So also on the guidelines is calcium supplements in divided doses. So there's an interesting publication, and Liz is a co-author in this. This is a question, is calcium always needed in patients with hypoparathyroidism? And this is an online survey in the members of the UK hypopara group. There may be a lot of you around who took part in the study. So they were asked about their current replacement regimen in relation to calcium salts and vitamin D analogs. And what I think is really, really interesting is that those you can see in blue, those who take calcium, and the orange one without calcium. And you can see that those taking calcium report more kidney stones, more emergency situations with low calcium, but also emergency situations with high calcium, more constipation, and more heartburn and indigestion. And the authors conclude that it could be feasible to consider a no calcium regimen in selected patients experiencing adverse effects from calcium supplements. Just to remind us all about the absorption of calcium, what do we know? If you take 500 milligrams, 30% are resorbed. If you take more, just 20% or less are resorbed. Calcium resorption is better with meals, and there's a decrease in resorption with age, so you need more. There's some interesting studies, what I think that we understand the calcium absorption situation. So this is in normal healthy volunteers, calcium bioavailability for mineral water with different mineralization in comparison to milk and a supplement. And you can see over the first hours after taking milk or several supplements, you can see that the increase in calcium in the first hours and then how it goes down. There seems a difference a little bit later during the day. And this is the calcium excretion. And you see that these are 2 hours, every 2 hours that it drops down, but there's a really huge amount of calcium then already in the urine after taking it. And if you look on the effect on PTH, this is healthy people, you can see that PTH drops, and now you get the feeling that milk is not as effective on PTH suppression than, for example, one of the other mineral waters or supplements. There's another very well done study, as I think this is 18 healthy male volunteers, and they were all in 6 weeks, one day they got one of this calcium supplements. So this one is a placebo. Here is calcium carbonate, mainly glucotactate and carbonate. This is citrate, this is calcium pedolate, and this is a hydroxyapatite complex. And what I think is really interesting, this is the first 3 hours after taking it, and you can see how high in healthy people the calcium level in the blood increases after taking it. So you have this is really huge amount of calcium, and this goes down after some time. And you get the feeling that the most efficient is the calcit. So this goes up the most, and this is the calcium citrate, which goes up very fast. And you have, this is the placebo, and this is what is the least increasing. And this, for example, is this calcium pedolate carbonate mixture. This might be, for example, relevant for those who take proton pump inhibitors, because citrate is nevertheless resorbed. So just to think about PTH, just a short reminder for us also that calcium, if you look at it for a few hours, that's a pulsatility in healthy people, that it's regulated also during the day, that it's higher in the night and lower during the day. And what is very important, this is data on people doing sports, that PTH is increasing while running, and also serum calcium normally is increasing in healthy people while running or doing sports. So what about the best conventional therapy? What can we say about it? So this is already, again, the Mitchell study. This is the Italian study. And you see the white areas should be, this is the people, there's 120 people from the Mass General Hospital, where we would think that's the best clinic wherever. So you can see the white are the normal values for calcium phosphate product and urinary calcium, and all the gray ones are out of the normal values in this clinic. And this is really great that they published it, because before nobody dared to publish these data like this. And this is the Italian study, and they showed that according to guidelines, just nearly half of the patients had all 4 values in the normal range, and 36 patients from 57 have 3 parameters in the normal range. So to reach the parameters according to guidelines seems to be difficult. So does it matter if the values are in the normal range? Does it matter or does it not matter? And it certainly does matter. You have already complaints, although the values are in the normal range, but also in this study we did, the values were also in the normal range, but nevertheless we found correlations to quality of life measurement with calcium, with serum phosphate, and especially with calcium phosphate product, and not just calcium. So we saw that the calcium phosphate product correlated to a number of complaints. So our suggestion was perhaps we should do our own calcium phosphate border and not just take it for the renal patients. As Peter already pointed out, in the medication with, for example, calcium is different in the United States. They use more calcium to bind phosphate, that's what they say. And in Europe, we do it differently, and we have less calcium. We have other and we take regularly also magnesium in the medication. So what about the best situation? So what our experience is that a lot of patients go to the primary care physician. They are not specialized, So they give up to 6 grams of calcium per day. And this is not resorbed, there's no 125 vitamin D available. So they don't understand the different aspects of therapy. They have no knowledge about or not good knowledge about the different vitamin D forms. They don't know anything about the goals of therapy, and they don't take into account the complications. The controls are not important enough and the values are not controlled. And this is the experience we have from our primary care physicians. And like this is a study we did when patients came to first visit and they had very high levels of calcium. And after some controls with the endocrinologist, they had lower values, lower supplementation of calcium in the last control visit. And actually, the side effects, what we can show is that if you look at gastrointestinal symptoms, you can see that no calcium is better than higher calcium levels make more gastrointestinal symptoms. So as Tanya already pointed out, so they are already also the medication influences the symptoms. So for long-term problems, we know that there might be renal complications, neurological manifestations, and manifestations on immune function. What we do not know how to we can change this. So what do we have about biochemical parameters? Why is it important that the controls are good? Because we know that high phosphate levels have effects on different aspects, on mortality, infections, and quality of life. We know that calcium phosphate product, and also from other studies, especially from the Denmark group with Lars Reinmark, they published a lot on this subject, that there's an influence on calcium phosphate product, also in the development, for example, on brain calcifications and on the neurological dysfunction. And we know that low calcium levels also have an increased risk of cardiovascular disease, also can influence neurological dysfunction. And we know that if you have very often high levels of calcium, this is also an increased risk for different areas, mortality, infections, cardiovascular disease, and renal diseases. Therefore, it's very important to have the values balanced. And treatment with vitamin D can be advantages. So what about the practical problems? So there might be in your everyday life, it can be that there are other diseases, gastrointestinal disease, diarrhea, that you get medication, glucocorticoids or osteoporosis medication, and this might change the calcium situation. So this might be an emergency situation, so there might be essential changing in treatment. Hypercalcemia situations could be a treatment overdose. In the summer, it could be intensive sun exposure, increasing your 25 vitamin D. It could be a decrease in renal function due to decreased fluid intake, or calcium phosphate binders, or other reasons. This can be an emergency situation, and this has to be treated very fast. We learned this, that it's essential that phases of hypercalcemia have to be treated fast. What about hypophosphatemia? Very important. As I showed you, that calcium phosphate product is important to keep low. So this is due to the missing PTH. I think this is showed Peter, and I also showed this to you. So this is a lot of phosphate is in the different diets. So you have to be aware that also this flavor enhancers, preservatives, acidifiers, that also this fast food contains a lot of phosphate, and it's just not milk products, it's a lot of other products. So this is change of diet, calcium medication, that's what's in the US is done to bind phosphate, decrease of active vitamin D, for example, of phosphate binders. And hypercalciuria is also due to the missing PTH. This can be due to also different parts, and you can try to treat it with thyroid diuretics, sodium restrictions, or even PTH therapy. And you have to really control for the stone forming parameters. So I don't have time to go into all the next ones, but there is also situations to treat hypomagnesia, hyponatremia, or hypokalemia in the different areas. So you have to be also aware that your doctor can change the medication accordingly. So in summary, so conventional therapy with active vitamin D is still the standard care in hypo-P patients. So as I showed you, vitamin D, genuine vitamin D should be added to active vitamin D treatment, just also to use the rest of PTH to have a more stable situation. So as we learned from the study, no calcium regimens might be considered in selected patients experiencing adverse effects on calcium supplements. I showed you that alpha-calcidol and calcitriol lead to comparable but high serum phosphate levels, hypercalciuria and physiological circulating 125. However, not all patients reach the target values for the relevant laboratory values in different countries. And I showed you that complication and symptoms are in part dependent on the disease, but also on biochemical parameters and also on the treatment. Thank you very much for your attention.
Thank you, Heide. I'll give the word to Helen, my co-chair, to introduce the next speaker.
Thank you. Thank you, Eriksen. I would like to introduce the Liz Glenister from the United Kingdom. She's a hypopara patient. She is the CEO and founder of the United Kingdom patient organization, Parathyroid United Kingdom. And the organization was founded in 2005, and Liz has more than 17 years of practical experience talking with hypopara patients. And the word is yours, Liz.
Thank you, Helen. Coping with practical problems in everyday management. As Heidi has so comprehensively shown, there are considerable problems and limitations in everyday management of hypopara, and there's still so much to learn about hypoparathyroidism and so much research still needed. So how do these problems affect patients and how can we best cope? I'm going to look at some ways that we can help ourselves to manage based on clinical guidelines, my own 30 years of living with hypopara, and 17 years of the knowledge that we've acquired from thousands of members and in our patient groups. So these are the problems that we are facing. Treatment, still not ideal or accessible for all. The condition itself not being properly understood, still fully understood. Research still needed, inadequate testing, and management being very difficult on a daily basis. The biggest problem that we find is lack of specialist care and specialist centres. The main problems that exist for patients appear to be caused mainly by a lack of understanding of the condition and mismanagement of calcium levels. So we have a poll here. What do you see as the biggest problem affecting you? Getting medication and calcium levels right? Lack of specialist care. My doctor doesn't understand hypopara. Getting a blood test done when I need it, or lack of parathyroid hormone treatment. You can choose any number. Oh, actually it says single choice up there, never mind, you can choose one. So what do you see as the biggest problem affecting you? Do we have an answer? Yes, so lack of specialist care and getting medication and calcium levels right are the top runners, 31 and 32% each. which is really interesting. Next on the list, lack of parathyroid hormone treatment, 22%, and getting a blood test done when I need it, 15%. Interesting. Thank you very much, everybody. So what can we do about these problems? So problem number one, my doctor says my calcium level is normal, but I feel terrible. So I think this is something that we all experience. And we need to look at the normal reference range here, which of course is not really suitable for us. Most people with hypopara have a very small window in that normal range within which they feel comfortable and can feel very unwell at the extreme ends of that range as well. So the whole picture has to be taken into account. Test results aren't the whole thing. You have to look at symptoms as well, because quality of life matters. Maintaining calcium at the lower end of the range is advisable for kidney health, but it's a real struggle for some people to be able to do. Having good vitamin D3 and magnesium levels can help with this and can help you feel better while maintaining lower calcium levels. And yes, we do need vitamin D3 as well as our active vitamin D. Problem 2, how can I manage my calcium levels and live my best life? Something we all aspire to do. So many of you are trying to maintain fluctuating levels as best you can without immediate test results, without knowing if your levels are high or low, often without being able to access your endocrinologist when you need to, without support from your family doctor, who often won't act without say-so from the consultant, and all while you're feeling very unwell and anxious. You're nothing short of heroic, but you need to take control. We have to take control. We can't be abandoned in between appointments without access to blood tests. So we have no choice but to self-manage. We have to do this to stay safe. And we have to take control of our own condition and be supported to do so. Patient groups can really help you with this. So the key points here, really paying attention, listening to your body so that you can monitor your symptoms, take notice of your diet and exercise levels, monitor your medication and arrange testing. Those three things together can help stability. Calcium levels fluctuate all the time in response to medication, diet, alcohol, fizzy drinks, stress, exercise, infections, anaesthesia, estrogen levels, and more. So it's not a simple thing to manage at all. And only you know when something is wrong and when you need to take action. So don't ignore that niggle. Eating a good balanced diet with regular meals and calcium-rich food can really help to keep your levels stable. Avoid too much dairy, which contains phosphate. Many people take too many calcium tablets and not enough active vitamin D, which makes your levels really swing and much harder to manage. So getting the balance right is really important. 2 calcium tablets a day are the maximum recommended and to be taken with meals. Along with that, you need vitamin D3 and magnesium to help keep your levels balanced. These really do make a big difference. This is the calcium protocol that we've been using that Heidi mentioned earlier. We found that people have been much happier on it, have had much more stable calcium levels, and much less hypercalciuria, urine in their calcium. So the key is maintaining good levels of active vitamin D, vitamin D3 and magnesium, and these three work together to help you get the calcium you need from your diet without using too many calcium supplements, which is much better for your kidneys and keeps you more stable. Keeping your calcium for occasional top-ups and emergencies as best you can, and using your diet to get your calcium works much better for your kidneys. So another poll here, poll number 2. Have you tried the calcium protocol and come off or reduced your calcium tablets? Yes or no? Have you tried the calcium protocol and come off or reduced your calcium tablets? Yes or no? And if your answer is yes, did you feel better? Yes or no? Can we have the results, please? So 70% of people have tried the protocol and come off or reduced their calcium tablets, and 43% say yes, they felt better, and 57% said no, they didn't. That's interesting. So that's completely different to the graph that Heidi showed us.
Liz, if I can maybe just, you could not send this if you pressed no on the first, because I'm doing this on my phone. If you pressed no on the first one, you were not able to send this without clicking anything on the second question. So people could have clicked no on the first one just to be able to send it. So that might have mixed things up a bit.
Okay. All right, thanks for pointing that out, Tanya. Never mind. At least we know 70% people have tried it, which is great. So what about testing? Blood tests are really important to help us manage our calcium levels. It's not always easy to tell if you're high or low. Levels fluctuate rapidly or they creep slowly up and down, and sometimes just cutting a calcium tablet or taking an extra one just isn't enough. Calcium levels don't stay stable from one appointment to the next, and a test is just a snapshot in a moment of time. So a test helps you and your doctor to know if your medication needs adjusting or if you need to go to hospital as an emergency. We all need regular blood tests, whether we're adults, newborns, children, teenagers, pregnant mums, and sometimes in a crisis we need it urgently, but this often causes problems. Access to testing varies widely, and access to test results can take way too long. We need the result now, not next week. So if you can set up an arrangement with your doctors so that you can access your tests and your results urgently when you need them, that can be really helpful. And yes, we desperately need a home tester like diabetics have, and there is good news on the horizon. A home calcium blood tester is being developed in the UK, and it should be ready to trial on patients this summer. It's been shown to work, it's accurate, and we really hope that before too long this will be available around the world. Latest results will be presented in Athens in May, and in Brighton in November, and we will keep you informed, and everybody's keeping their fingers crossed for this. Problem 4, how can I avoid going to hospital? Nobody wants this to happen, but sometimes it's necessary. So what can we do to try and avoid it? Don't ignore your symptoms. Listen to your body. I've said it before, but I can't say it often enough. Learn what your symptoms mean so that you can take action. It's always better to at least have a yogurt or a calcium tablet straight away and stop the drop, rather than let things get worse and harder to control. That might be all you need to do. But sometimes, and sometimes you might not need extra meds, you might just need to take your tablets a little earlier than usual. If your doctor wants to adjust your meds, make sure this is done in the smallest possible steps and gradually. We see too many people admitted to hospital because their meds have been increased or decreased by too much too quickly. And if you can't control things yourself, then you do have to go to hospital. There's no question. But there are emergency medical cards available in some countries. Germany and UK now have them, and the ESE also has their own card, which you can find out about through your endocrinologist. These are really quite useful if you get to the emergency department and are having trouble explaining what's happening to you, or the person you're dealing with hasn't come across the condition before, which happens. Poll number 3. Have you been admitted to hospital after your doctor adjusted your medication? Have you been admitted to hospital after your doctor adjusted your medication? Yes or no? Could we have the results, please? Yes, 30% of people have been admitted to hospital after their doctor adjusted your medication, and 70% have not. So I'm glad for that 70%. And finally, how else can I help myself? As Natalie and Tanya have already said, take control. This is the most important thing, and you will feel a lot better doing so. Find information, learn everything you can. There's a lot of detailed information on all our websites. Learn how the problems affect you, because this is a very individual condition and everyone is different. If your doctor hasn't met another hypopara patient, hopefully they'll be able to work with you to learn together about your condition. But if that's not possible, and it often isn't, then ask to be referred to a specialist. And finally, find a patient group. Sharing experiences with others is just enormously supportive and helpful, and fellow patients will become your lifelong hypopara family. Yes, there are problems, and there's still a long way to go, but together we have learned a lot. We've made a lot of progress, which is making a difference now and will do for the next generations. This hasn't been long enough to cover everything, but I hope it's helped. So please do go to your patient group to learn more, and thank you for watching. I hope we have some time for some questions. Thank you.